Welcome, everyone. Thank you so much for joining us. Our webinar today is entitled Dynamic Pairing, the GI Effects and NutrEval Applied to Clinical Practice. And our dynamic speaker is Dr. Stephen Goldman. My name is Dr. Lenore Powell, and I am a medical education specialist in Genova's Atlanta branch, and I will serve today as your moderator. We would like to welcome Dr. Stephen Goldman. Dr. Goldman earned his Bachelor of Science degree from the University of Massachusetts. He received a doctorate of chiropractic from Cleveland Chiropractic College, where he also served as a member of the faculty. Following 25 years of family practice in Los Angeles, where he worked largely with athletes and patients concerned with optimal health, Dr. Goldman relocated to Asheville and joined the medical education team at Genova Diagnostics. As a medical education specialist, Dr. Goldman provides educational support to physicians and also authors medical education support materials as well. In addition, you will have access to the presentation and the slide deck on our website within a few days after the webinar. You can access those resources, previous webinar recordings, brief video modules, and other materials by clicking the Clinicians tab on the home page. With current events prompting clinicians to do non-acute patient appointments through telemedicine, please remember that we still do offer many non-invasive urine, saliva, blood spot, and stool collection package that can actually be shipped directly to your patients for specimen collection at home, and the requisition can be completed online. For more information, please visit your LiveGDX account.
Hi, Steve Goldman at Genova Diagnostics here, and I am hoping everybody is well, and thank everybody for coming to this webinar. We're very excited about it. It's the first time I've ever actually done one from home, so it should be very interesting. Thanks for that wonderful introduction. I would only add that I think it's time to update my picture. I think that one was taken at my bar mitzvah. So let's see if we can get these slides. There we go. So the objectives for this presentation are to discuss updated GI effects statistical data. Some of you may notice that we have updated the GI effects, particularly the front end of it, in fact, only the front end, in terms of some of the statistical information. And I would highly recommend Dr. Chapman's webinar on that subject, although we'll go over a lot of that again today, and to identify concepts that connect nutritional assessments with stool testing results. And then finally, we're going to provide interpretation and application of laboratory results through case studies. So I have a couple of case studies ready to go. I wanted to take a look at this slide from a 2018 article, Microbiome Research is Becoming the Key to Better Understanding Health and Nutrition, and how, however, nutrients, metabolites, microbes are increasingly regarded as key players even where the complete disease mechanisms remain unclear. So in terms of the new GI effects comprehensive profile, be aware the first 3 pages have changed. We're going to talk about that. The test itself, the actual test from page 4 on, is exactly as it always was before. So here we have a front page that we'll talk about with some changes, and a second page of statistical analysis, really commensal analysis, and then a third page. So these 3 pages constitute the different changes, but the test itself has not changed. Much of what we're describing here is a result of feedback from doctors who wanted more data in terms of interpretation, and we've provided that. So this page 4 is exactly as before, with digestion, absorption, inflammation, gut microbiome. And here we have the PCR DNA findings, the 24 DNA findings for the 24 commensals. And remember, commensals, Latin for at the table, belong there. They're not in and of themselves pathogenic at all, but it's an imbalance that often is an issue, and that's why we try to accumulate data in interpretation of that. Another aspect of the test that I think is so important and has always been there is culture, because with culture you get to see what's growing, what's viable, and you also can run sensitivities when you have a potential pathogen or pathogen. So this would be the page that incorporates culture. And then we also have these O&P, microscopic evaluation for parasites and worms. And I think also it's really important and a great advantage in any stool testing to get a look under the microscope. What can you actually see there? It also provides you a much wider range of possible findings. But in addition, we have the PCR DNA findings, and we'll talk about all this as we go through the test. And we also have some add-on testing as well. And this would be an example of a culture, a sensitivity, so that you can actually specifically treat the culture of the organism in question. And there's another one around a Klebsiella. So the test itself is the same. Some of the findings in the front are really a statistical analysis. So I wanted to review that. As I said, we have a pretty extensive webinar on that from Dr. Chapman, but have been on the phone with a lot of you out there, and this has really been something we've been talking about. So we tried to change the results overview a bit to make it easier for the patient and physician to sit down and discuss this and really get a sense of what's going on. So here you see the icon there, which is a graphic that we'll talk about that is very specific to the findings beneath there. It's an evaluation of the key functions of the GI tract, so the digestion, inflammation, and gut microbiome. And then we have the functional imbalance scores. This is like a scorecard or a report card, and I think the great benefit of this is you can really sit down with your patient and say, here are the different findings. So under maldigestion, we have a color coding and a number. Inflammation, dysbiosis, metabolic imbalance, and infection. And we'll talk about this some more as well. But I think a great advantage of this is not only being able to see the test now, but if you decide to retest in 3 months or 6 months, you can sit down with the patient and get a very clear understanding of what the findings were. And then we have therapeutic support options. So underneath there, and this is the only really static part of the page, where we actually have therapeutic options in terms of treatment for you to consider and discuss with the patient when you're designing your protocol. So this is that icon. We have the digestion. So you can see under digestion, that maldigestion in yellow. That yellow corresponds to your patient's findings. It's not static. And then we have the inflammation, as you see here in red. That would be a high need to treat inflammation, a high need. And then the gut microbiome, which is divided into 3 parts: infection, metabolite imbalance, and dysbiosis. Again, these are color-coded to your patient's findings on the test. And then we have the functional imbalance scores. Once again, this is an algorithm-derived score for each key functional area. So it's based on the biomarkers listed. So in other words, when I see this 5, this yellow, remember, yellow is a moderate need. We've actually added also a gray 2 to 3 for optional need. Green would be a low need, of course, high need in red. So here we have a yellow moderate need at 5. These are the markers: a low pancreatic elastase, a normal product of protein breakdown in fecal fat that the algorithm utilizes to come up with that 5. And that's all straight across. And these will all be very familiar to you, except when we get to dysbiosis, and we'll talk about the IAD methane score in detail in just a moment. So it's a 2-factor weighted algorithm. We're looking at the severity and the abnormality, and also based on the clinical importance of the biomarker. And the higher the score, the greater the dysfunction, the higher the need for support. So I think you can see that this gives you a very immediate look at what's the rating, what's the need, what are the markers that led us to that. And then, of course, therapeutic support options. So as I said earlier, a lot of this is a reaction to the Commensal Bacteria page, these 24 DNA findings. Clinicians are often asking us about, what do we do with these DNA PCR findings? We talk about imbalances. Again, they're not pathogens. They belong in the gut. Often the metaphor of your gut's like a garden. There are certain things you expect to be growing there, but imbalances, if something grows over something else, can really lead to difficulties. And so we're always trying to find ways to really look at this with a fresh eye. There are some historical limitations because in the literature, you see different methodologies in measuring. You see discrepant results and publications around the meaning. And there's some unknown clinical importance for specific individual bacteria and no research into bacterial patterns. And that's really where we feel we focus very strongly, because we have so many of these GI effects, such a large pool of patients to look into pattern analysis. And I think you'll find that that's very, very helpful. Now, when we do that, this novel approach to the microbiome analysis, a lot of this is going to be familiar to those of you who have done this test in the past. Really, the biggest difference is going to be this section of dysbiosis patterns, and we'll talk about the inflammation-associated dysbiosis IAD score and methane dysbiosis score in a moment. But the rest of these should be somewhat familiar. In the past, on the GI effects, on the front page at the bottom, we would have this commensal balance and relative abundance. And really, these are still both represented on the test. The commensal balance really has not changed. The relative abundance is an upgraded graphic that we'll look at, but this information is still there. You see, for example, in the relative abundance, the various color-coded phyla, and you see that on these healthy cohort and patient results columns. But we've just changed the way we lay that out now. So it's really all based on the commensal bacteria. So the Firmicutes phylum is a dark blue heading. The various phyla are going to be in dark blue, and we look at those, and then also the highs and lows from the reference ranges. So this is really a lot of the data that we're looking at, especially when we look at the commensal balance. So the commensal balance is a composite of two measures. The x-axis at the bottom, that 0 to 24 score, represents the 24 PCR commensal bacteria on the test. So that's our x-axis. Our y-axis, and you see the 8. Let me not skip over that. What that tells us is from 0 to 24, there were 8 of those bacteria on the commensal 24 that were outside the reference range, either high or low. And then we have the y-axis, the healthy pattern continuum, which is a progressive ranking scale differentiating healthy and unhealthy commensal patterns, where we took targeted commensals and ran them through an algorithm. On a scale of 0 to 10, the higher you are in that scale, the more likely to be in the green or yellow. The green or yellow represent healthier commensal patterns, whereas the red would be more unhealthy. So between 8 outside the reference range and a 0 to 10 scale 1 on the healthy pattern continuum, this patient is now bridging to the red, to the more unhealthy pattern. Now, the good news is, if you're accustomed to this, is that on the new test, it looks like this. It's exactly the same, unchanged, except instead of the black diamond, we have this circle that says U, indicating where your patient's score was. Now, the relative abundance, we have these two towers, the healthy cohort, representing the overall total abundance from the commensal 24, from the healthy screened cohort that is utilized for the reference range. And then to the left of that, we would have your patient's results. Notice they're color-coded to go with the various phyla as well for comparison. So what we've done now is we've pulled that and knocked that patient result on its side, and then we got rid of the healthy cohort tower and replaced it all with this total commensal abundance. So whereas this tower from here to here would now really be this healthy cohort from here up to 100%. So this is exactly the height of that healthy cohort. And now you can see, where does my patient fit in terms of a relative abundance? And we're well here, about 20 to 25% higher. So in the old test, that would be represented with this tower being about 25% higher as it is here. Now, what does that mean? Well, a high commensal abundance may mean a microbiome overgrowth. It may be a good thing. It may be a patient on probiotics and prebiotics and fermented foods, but it may also be a SIBO patient. But the relative abundance is higher. If it's lower, a potential microbiome deficiency. Now, the next thing we did is we looked at the various phyla, the color coding, and instead of laying it out like this, we actually list it and have the same color coding, but here, instead of comparing the healthy cohorts to your patient, we just lay it out here. So the healthy cohort would be from here. So from left to right up to here is where the healthy cohort is. So in this case, the Bacteroidetes phylum was about 30% higher than the healthy cohort. So the same information as the previous incarnation, we just feel it's laid out a bit more easily understood in a more understandable manner, especially for the patient. And in addition, what we did add on is some text, so that when you see an elevation of the Bacteroidetes phylum, you can tell the patient that it increased in Bacteroidetes species and Otorobacter seen in animal-based diets. So it actually provides context that wasn't there before, so you can really talk to your patient about this. Now, I mentioned earlier that the new part of this were these patterns, the dysbiosis pattern. This is a novel biomarker that is unique to Genova and our GI effects only. And it's based on internal data analysis of commensal patterns. And so we have what's called the inflammation-associated dysbiosis score, an indicator of the dysbiotic pattern associated with GI inflammation. And we also have a methane dysbiosis score, which we'll talk about in a moment, which is an indicator of dysbiotic pattern associated with methane production. But if you look at this inflammation-associated dysbiosis, you can see that anything from low to 30 is normal. So 36 would be a little high. And the methane score also, anything from 0 to 5 would be normal. Higher than that would be a little bit elevated. And then we graphed it out with the inflammation at the bottom and the methane score on the side. So the inflammation-associated dysbiosis score, IAD. So what are we looking at here? Well, when we look at this, we're looking again for commensal patterns. So what we did is we looked at patients who did the GI effects who had inflammatory findings, calprotectin, eosinophil protein X, secretory IgA, and we asked the question, when we see inflammation, are we seeing some sort of pattern amongst the 24 commensals? If so, that gives us some data that we can really look at for each patient. So we correlated the inflammatory biomarkers to an algorithm derived from commensal bacterial analysis. So that's the inflammation-associated dysbiosis. In other words, we looked at over 7,000 cases and said, okay, the 7,000 with inflammation, when we saw inflammation, what was the pattern of those 24 commensals? Interestingly, one of the things that we noticed was, more often than not, there were lower bacterial findings of those 24 commensals associated with a high IAD score. So the tendency was with inflammation, lack of abundance, lower numbers in terms of a lot of the, not all, but a lot of those commensals. And I thought that was a very interesting finding. Now, the methane dysbiosis score was a little different. We took patients who had done the GI effects and also did the SIBO and found that they had a SIBO test and found that they had a high methane score. So we had these 24 commensals so we could look for patterns. We had 1,786 patients that also had a high methane finding on the test. So we correlated those to see, were there any trends? And there were. You can see here, there's the high methane. That's where the methane is reported. So the methane dysbiosis score is a specific dysbiosis pattern associated with high methane production. It's correlated with methane production on the SIBO test based on commensal bacterial profile and stool biomarkers. And it was developed as an algorithm to score to predict higher methane production in the GI tract. In other words, when we saw that high SIBO methane, we saw that there were certain patterns of the commensal bacteria, and we also saw other markers. And one of the things that was really, I think, the most fascinating is that we saw that the immune markers, the inflammatory, the GI effect, calprotectin, secretory IgA, and eosinophil protein X tended to be lower, tended to be muted. So individuals with high methane production had a statistically significant higher rate of infection with potentially pathogenic organisms also, like blastocystis and Entamoeba histolytica. So here we have with this methane score, patients, and again, it's a tendency, It could be different for each individual patient. But having looked at those 1,700 cases, lower immune response, and more of these pathogenic, potentially pathogenic organisms showing up. And then we took both of these and graphed them out. So here we have the x-axis is the inflammation, the IAD score. Here you see it up there registering at 36, a little bit high. So you see where that X is here, is exactly where we cross that x-axis. And then for the methane score, at 9, we're over here, and that puts our patient right there in zone 3. And then we have on the page the various zones. So patients in this zone, statistically, may have more inflammation compared to those in zone 4. Why? Because there's more of this immune suppression and also an elevation of inflammation, both. However, commensal abundance is usually higher, making use of antimicrobial therapy relatively safer. Patients in this zone may have higher rates of pathogenic infections. So by having these 4 zones, we're able to give you a database to evaluate your patient. A great add-on, I think, to looking at those 24 commensals. Now, that's everything that's changed on that test. We'll look at the rest of it in the context, hopefully, of these 2 cases. The NutrEval starts off with an overview. It's our most comprehensive test in terms of looking at nutrition. And we're always looking for patterns here as well. There's a suggested supplement schedule, an interpretation at a glance, also a review of the Kreb cycle findings with organic acids. Here are the organic acids. The amino acids, either plasma or first morning void, are available. And then essential metabolic fatty acids, oxidative stress markers. So I know I kind of went through that pretty quickly, but I want to make sure we get to these cases. And I think we'll see all of these as we go through the case. So what we're trying to do here is combine findings from the NutrEval with findings of the GI effects in a clinical environment, in a case study. So our first case involves this 54-year-old gentleman who complains of intermittent, non-specific abdominal pain with chronic constipation. He doesn't report a postprandial association. Endoscopy and colonoscopy were unremarkable. High stress, he's an assistant principal in a middle school. Standard American diet, animal protein, low fiber, no medications were reported. His exercise is pretty limited, 20 minutes twice a week. Someone with a high stress job, that's not a lot of exercise. So let's take a look at the testing. So here's our GI effect. I'm going to go back to that for just a second. So you can see when we look at this, we can immediately tell maldigestion at 7, a high need. We can see the markers, the fecal fat elevation, low products of protein breakdown. And here are some of those supportive options. The inflammation, not bad at 2, optional need for support because of a high in yellow, not that high, eosinophil protein X, a dysbiosis of 10, a high score, and a metabolic imbalance that's high as well as a low infection. So no indications of a parasite, a bacteria, or yeast growth. So we can step back and get a sense of what are the hotspots: maldigestion, dysbiosis, and metabolic imbalance. So when we look at his commensal microbiome analysis to see how abundant is he, there's the 100%. That's the healthy cohort. He's way up there. He's about 20% higher. So he's got a high relative abundance. Pretty well populated finding. And then his relative commensal abundance in terms of the various phyla, well, you know, we can see, for example, as Bacteroidetes is a little high, increase seen in animal-based diets, and that sounds just like our guy here. And we also see an elevation of the proteobacteria. Some species may be pro-inflammatory. So he's got a very abundant looking gut microbiome based on the 24 commensals. So what about these dysbiosis patterns? Well, here's our x-axis for inflammation. We can see that inflammation was at 15, which is below the 30. So that puts us in zone 1 so far. But we also see that his methane dysbiosis score at 13 was high. So that will put us in zone 2. Not much inflammation, but a high methane score, which, by the way, you may notice is called the immune suppression because of the lower immune response we typically see here. And so the question is, well, what do we see in zone 2? And there it is. The pattern is associated with impaired intestinal barrier function, a low secretory IgA and eosinophil protein X in terms of immune blunting. Patients have higher rates of blastocystis, dientamoeba, as well as fecal fat malabsorption. I don't think I mentioned that earlier. With a high methane dysbiosis score, we tend to see high fecal fats, as well as fecal fat malabsorption, and commensal abundance is higher in this group, suggesting potential bacterial overgrowth. So we get our graph, we get our zone, and it gives us some insight into what may be going on with this patient. So this is the source of that statistical analysis. Once again, the highs and lows on the PCR DNA. There were 9 of these bacteria either high or low to the reference range. So the reference variance score is 9, and that's what we were looking there. By the way, this reference variance score is also mentioned under dysbiosis on the front page, but you can see that the healthy pattern continuum was at about a 9. So between those two, he's kind of right. He's hedging between the yellow and red as far as his commensal balance is concerned. So what about the score and the meaning here? So when you look at the first page of the actual test itself, we see the pancreatic elastase at 319. Now that's considered a pretty good pancreatic elastase greater than 200. But be aware of that, greater than 500 is really optimal. So even though he's at 319, there may be some need here. I would certainly keep an open mind to that possibility. The products of protein breakdown, the valerate, isobutyrate, and isovalerate, are low. These are made when you break down proteins and you have amino acids and peptides and dipeptides. Are they being well absorbed? If they're malabsorbed in the small gut, they'll be fermented by anaerobes, making these products of protein breakdown. So a high number here would indicate poor protein breakdown and absorption. Here we have kind of a low number, which is encouraging in that he does seem to eat a lot of meat, perhaps, and so he seems to be doing well with his protein. But look at his fecal fats. They are really high. That does go along with the methane score, but also with his diet and a lack of absorption. So if we remember the front page, that's what the maldigestion looked like. High fecal fats, kind of a low product of protein breakdown. And you may ask, well, why would that be a problem? Some people have a low product of protein breakdown because they're just not eating enough protein. So it's certainly worth noting. As far as inflammation, calprotectin, and a very important inflammatory marker that can distinguish between inflammatory bowel and irritable bowel, looks just great. But you see the eosinophil protein X slightly elevated, not too bad. And we see the fecal secretory IgA below detectable limit. Remember, you had a high methane score. I wouldn't expect too much in terms of inflammation. And we have that eosinophil protein X just slightly elevated. That can happen from food allergies, for example. And then, of course, the gut microbiome metabolites. The short-chain fatty acid total is low, as is the M-butyrate. Short-chain fatty acids are beneficial. You really need them. So they're made when anaerobes break down fiber. So when you see a low number like this, it may be, we know he's got a high anaerobic count, a need for fiber, as well as the low M-butyrate, which is a low percentage of a low number. Also, the beta-glucuronidase is slightly on the higher end, and it does take fiber to break that down. We also see imbalance amongst the 3 short-chain fatty acids. High acetate, for example, relative to the others. So that also would constitute an imbalance, and that's why we have that 9. So here are the commensals. I always look at the lactobacillus here, which is actually low in the DNA. Remember, DNA is about viability. How many? It's a head count, basically. The bifido, also low. Interesting, with a high overall relative abundance to have such low numbers. The E. coli looks good, and those are high. And look at Methanobrevibacter. That's the main methane producer in the gut. And so that would speak to a high methane production. The culture, when we tried to culture lacto, E. coli, and bifido, remember, lacto was low in number, and we couldn't isolate it in culture. Not unusual specifically with lactobacillus. Hard to culture and isolate. So that no growth isn't so unusual, but paired with a low count in the DNA, that speaks to a need. The E. coli was high in number and cultured strongly, but the bifido was low in number in the DNA and also cultured very poorly, not that viable. So a strong need for probiotics here. And then we took the stool and put it in a culture, and whatever grew out, grew out. And these are two non-pathogenic bacteria. There were no yeast findings. The mycology is a culture specifically geared to yeast. No finding there. So then we look under the microscope, and you can see there are no detections of worms or parasites. This is not an exhaustive list. We look for even more than this. DNA can only find, when you're looking for parasites, you can only find the specific organisms that you're designed to look for. So it's very limiting. With the O and P, you actually, whatever you see, you see. So it's a much wider range of detection. Of course, we combine both on this test, DNA and microscopic exam, a much wider net than DNA alone. And this is the DNA here. You can see we look for blastocystis, not detected. None of these were detected. But I bring up the blastocystis because if it had been detected, we would have also done a second reflex subtyping to see if there was a specific subtype that we could find. But there was no detection of blastocystis, and the patient indicated a hard constipated stool. So key findings: high fecal fat, low products of protein breakdown, so good protein breakdown and absorption. Fat not so good, a moderate pancreatic elastase, a slight elevation of eosinophil protein X, high reference variance, so a lot of outside the reference range findings on the commensals, a high methane dysbiosis score, high total abundance, very abundant, low short chain fatty acids with a low N butyrate, and then a hard constipated stool. So when we look at the NutrEval, now we're looking at nutritional evaluation, and I'm looking for patterns here on the front page. Vitamin C and alpha lipoic acid, a moderate need, but a lot of B vitamins. So right now, the headlines are moderate antioxidant need, lots of B vitamin need. This is the suggested supplement schedule, a continuation of that. So that middle column are our recommendations based on the algorithm. And we did see antioxidant needs. We did see B vitamin needs. There was a high need in red for probiotics and a moderate need for pancreatic enzymes. And that fits pretty well as what we just spoke to in the GI effect. We also have the amino acid recommendations on the bottom. Not much there with the exception of glycine. So these are the organic acids, the malabsorption dysbiosis. So that elevation of DHPPA may speak to some degree of a need for probiotic support, telling us that there may be malabsorption of certain amino acids that comprise this. That would be the tyrosine, tryptophan, and phenylalanine being poorly digested and or absorbed. And then we also have the neurotransmitter metabolites. And here we see a high 5-hydroxyindolacetic acid. This is a byproduct of serotonin. Now, if a patient is on SSRIs and this patient isn't, it could be high if they're on 5-hydroxytryptophan. The pathway is tryptophan to 5-hydroxytryptophan to serotonin. But remember, serotonin is not going to pass through the blood-brain barrier. 95% of it is in the gut to help with gut motility. 5% is in the brain. So this 5-hydroxyindolacetic acid may also speak to a need to help the gut. And then we also see the kynurenic acid, which is sometimes needed for B6 to be broken down, but also it's kind of an alarm clock that can tell you, hey, in the presence of inflammation, in the presence of stress or high cortisol, you'll start to generate more kynurenic acid as protective. The vitamin markers, elevations of these speak to specific B vitamin needs. So here we see the high Figlu is a very important folate indicator and somewhat B12, xanthoranic acid and B6. These are organic acids that need specific B vitamins in order to break down. If those B vitamins functionally aren't getting it done, you'll have a higher concentration of the organic acid in the stool. Excuse me, not in the stool, in the urine. The toxin and detox markers, we see that there's this styrene, which is from styrofoam, plastic. You use the microwave with those plastic wraps. And then the alpha hydroxy isobutyric acid from MTBE, which is a gasoline additive that is still in the water. So he is susceptible to some of these toxics. And his pyroglutamic acid a little high. We'll see what his glutathione looks like. This is a precursor to glutathione and a breakdown product of it. As far as his cellular energy and mitochondrial metabolites, these are the Kreb cycle findings. And if we look at these, we see that the beta hydroxybutyric acid is high. This is a ketone body. So you wonder, why a high ketone body? Is it a low carb diet? Is it pre-diabetes, diabetes, low carb intake? I think I mentioned. It's certainly not from a starvation diet. He doesn't seem to be on a ketogenic diet, but he does eat a lot of protein. Maybe he's lacking in carbs. And when we look at the amino acids, what I like to look at is what is the essential amino acids pattern. And so I draw this plumb line, and I say it's a rather overall moderate pattern. Some a little higher, some a little lower. And so my question becomes, what is the dietary intake of protein? Is it moderate? And when you look at this, it really does appear to be. 1-methylhistidine is a very good indicator of dietary intake of protein. So he's not doing badly as far as he seems to be eating a moderate amount of protein, and he seems to have a moderate path of amino acids that are essential from his diet. The 3-methylhistidine at 0.54 could indicate meat. It could also indicate a breakdown of his own muscle. And then the ethanolamine elevation is a very specific magnesium indicator. You need ethanolamine going to phosphoethanolamine, and that's a magnesium-dependent step. As far as its essential and metabolic fatty acid markers, his omega-3 index is low. Well, moderate, excuse me. Moderate. You can see here are the omega-3s. When I add the EPA to the DHA, I get the 6.9. That's my omega-3 index. And anything under 4 is going to get my attention. 8 to 10 is considered ideal. Not bad, but he's got a low DGLA. And DGLA is a very important anti-inflammatory, even though it's an omega-6. High percentage of saturated fats as well. And that may be from his diet, which we think is that standard American diet. Now, if we look at the pathway of the omega-6 family, I mentioned he had a low DGLA. You see it there at 0.62. People are always looking at the arachidonic acid as a pro-inflammatory, but the DGLA is a very important anti-inflammatory. You want this in the green. It comes from the conversion of the GLA above it. And so in this case, you might want to give GLA in the form of evening primrose, borage, and blackcurrant, so that there's more substrate to convert into the DGLA. But you also might want to take a look at the elongase cofactors, some of those B vitamins that we've been talking about. Oxidative stress, well, his glutathione is a little low. Earlier in the organic acids, his pyroglutamic acid was a little high. He may be struggling to make more glutathione. Certainly, we saw toxic exposures. And we also see that lipid peroxides are in the yellow, which is a little high. Lipid peroxides indicate measurable oxidative stress, oxidation of lipids like cell membranes. As far as his toxic elements and nutrient elements, he seems okay here. You see his toxic elements look good as well. But remember, we did see the MTBE, which is a gasoline additive in the organic acid that is toxic. And we also saw the styrene high. So there is some toxic exposure to address. So let's compare the two. High fecal fats with low product of protein breakdown and moderate pancreatic elastase from the GI effect. A slight elevation of eosinophil protein X, low short chain fatty acids, low N-butyrate, a robust beta-glucuronidase. So those to me add up to a need for fiber. High total abundance, so he's got a very populated microbiome, and a high methane dysbiosis score, as well as a constipated stool. But what about the plasma amino acids? Well, a high need for B vitamins, a moderate, the NutrEval, the moderate antioxidant need. Lipid peroxides were high, glutathione was low. A high need for probiotics, moderate pancreatic enzyme need, toxic exposures, the chynurenic acid, which may signal a response to inflammation, or oxidative stress. High saturated fats with low DGLA, that's pro-inflammatory. So what are our treatment considerations? Well, we could test for SIBO to determine the diagnosis and allow for increased probiotic and fiber supplementation. So he doesn't have that bloating that's linked postprandially, which you would expect with SIBO. On the other hand, there's so much indication for the need for fiber, you might decide to do a SIBO test, because with SIBO, providing prebiotics and fiber could worsen the situation. So one could do a SIBO test just to make sure. Pancreatic enzyme support, I think, makes sense from both tests, and consider bile salts or digestive bitters for fat digestion and absorption. Evening primrose or borage for low DGLA to relieve inflammation from the essential metabolic fatty acids. Antioxidant support, vitamin E, C, lipoic acid, glutathione, all indicated. One might consider garlic-based botanicals for gut methane levels. Remember, his Methanobrevibacter smithii was actually elevated on the 24 commensal page. Bear in mind, that healthy screen cohort, 70% of them are below detectable limit for Methanobrevibacter. This patient was elevated. So garlic-based botanicals can be effective in helping with Methanobrevibacter smithii, but I would still lean to doing a SIBO test. I would say adjust to a more balanced diet, because it just seems like this standard American diet is not working out. And maybe design a consistent exercise protocol to relieve stress. Consider an adrenal cortex stress profile with cortisol awakening response. Stress can be a big part of this. Getting good rest, having a good balance of the adrenals could also be a big part of treating this patient. And my hope is that we've been able to look at this and get a sense of utilizing both the NutrEval and the GI effect to kind of come in conjugation to a protocol that's really comprehensive. And I think the tests really work so well together. Now, I know that I had a second case, a 42-year-old female, intermittent postprandial constipation with abdominal discomfort. She has difficulty gaining weight. She's thin. She's frail. She hasn't cycled for the past 6 months. Chronic use of antibiotic therapy for gut issues. Stress is high. A light appetite, very little meat or protein intake. Feels tired, difficulty sleeping, muscle aches, and just takes a multi-mineral at this point. So here are our GI effects, and we can see dysbiosis is high. Metabolic imbalance is high. So those are going to be the main areas of concern here. And you can see the various markers that are involved. As far as her commensal balance, and again, we're looking here at the GI effects right now, the first 3 pages, we can see here that she's very low. Look how low she is in her commensal. There's the healthy cohort. We're way down here. Before the first test, we were way up here. So she's really depleted. She's been on antibiotics a good long time. You can see it in the relative abundance as well here as far as the various phyla. Look how depleted she is. As far as her commensal balance, she's at a 9 here, along with an 8. So she's in the yellow, but really depletion of the microbiome is the key here. And so we see her inflammation-associated dysbiosis is a little high, and her methane dysbiosis score is not. So she's right there in zone 4. In zone 4, that's associated with an increased intestinal inflammation. The IBD patients are more likely to have this pattern of bacteria. Commensal abundance is lower in this zone. Remember, higher inflammation, a lower tendency. But when you treat someone like this, antibiotic use for GI potential pathogens should be used with caution. In addition to standard treatment for intestinal inflammation, modulation of the commensal gut profile is encouraged. In other words, once you're in zone 4, you're probably pretty depleted. And in that depletion, using antimicrobials is probably going to be contraindicated. And I think we've seen evidence to that all along with this patient. So here we see the pancreatic elastase is kind of on the low side, but her products of protein breakdown are low. But in this case, I would think it may be about a need for more protein in her diet. There's a big difference between having a lower products of protein breakdown because you're eating protein and breaking it down and absorbing it, as opposed to just not getting enough protein. Even her fecal fats are a bit low except for the cholesterol. As far as inflammation, and here you see it, that low products of protein breakdown in this case is an issue. She does have inflammatory markers. Her eosinophil protein X just slightly high, and her secretory IgA just slightly high. So it's not a big amount of inflammation, but there is some there. And then here we have the short chain fatty acids, again, really low. But in this case, it may be a need for fiber. But remember, anaerobic bacteria are required to break that fiber down. And she doesn't have that, so she may need both. And then the beta-glucuronidase, which is an enzyme that recirculates toxins in the gut. As it gets higher, there's a greater risk in the literature at 13,000 or greater of colorectal and breast cancer. You want to keep that low, and it does take fiber to do that. You might also give some support around ascorbic acid and calcium D-glucarate, which may not lower beta-glucuronidase, but can certainly help minimize its effect of recirculating toxins in her gut. Overall, you can see how low. The pattern is so low. The bifido is low. The Akkermansia, which I haven't talked about before, Akkermansia is an interesting one. Mucinophilia, mucin, mucus, phila to love. It helps with the mucosal lining. You want this to be robust, especially with a higher secretory IgA, which means damage to the mucosal lining. Pomegranates, cranberries, inulin are all great ideas with the low Akkermansia. And then that chronic antibiotic use. As far as the culture, again, the lacto didn't grow out. The E. coli did, but the bifido not so strong. So again, the DNA, a low number for bifido, and then a low growth as well. And the lacto also had a low DNA. So in that case, I would certainly recommend lactobacillus as well. The additional bacteria that grew out, all non-pathogenic, although the Citrobacter, if it had reached this yellow, would have been changed to potentially pathogenic. And every patient is different. We can't know if it's an issue for her, but in this case, you have to take into account antimicrobials may not be worth it to knock out a potential pathogen that might just be moving through. She needs to reinoculate. As far as the O&P, nothing seen in the parasitology under the microscope, nothing seen in the DNA, and no occult blood. So again, you really cover your bases fully with an O&P microscopic look and the DNA both, as well as bacterial and yeast culture. Some people say you don't grow yeast very well. I speak to our lab, the microbiologist assures me that yeast grows out very well and is well worth looking at. As far as the NutrEval, if we look at this, antioxidant needs, B vitamin needs, some zinc, it's all listed here, but a lot of amino acids as well. Probiotics are recommended too. So some gut stuff, low protein, need for antioxidants and B vitamins. When we look at the organic acids here at the Kreb cycle and at the digestion, we see the 3-hydroxyphenolacetic acid is elevated, citramalic is close. So these are going to be where these recommendations come for probiotics, an indication of maldigestion and or malabsorption in the gut. As far as this adipic acid elevation, remember, fats, carbs, and proteins are the macronutrients in the mitochondria, acetyl-CoA, that fuel energy production. When you see high adipic acid, that tells me she's having a hard time digesting, utilizing, oxidizing fats for energy. And that's problematic. And it speaks to a need for carnitine and magnesium. So fat oxidation is an issue for energy. And look at her pyruvic acid, how low that is. She may be on a very low carb diet as well, but she's on a low everything diet. And I think that that speaks to these organic acid findings. High adipic acid, low pyruvic acid are both problems, as well as the need for reinoculation. The 5-hydroxyinolacetic acid is that byproduct of serotonin. She may not be making much serotonin because she may be very low in tryptophan, but she may also be having gut issues that speak to a need for serotonin to be metabolized in the gut. So that can also speak to her gut issues. Oh, and the kynurenic acid elevation as well can be a signal of oxidative stress and inflammation, a warning, as well as the need for B vitamins, specifically B6. The amino acids, look at that pattern of amino acids. This is why the products of protein breakdown are an issue. And you can see our 1-methylhistidine is low as well. So she's not eating protein, so why would I expect her to have an essential amino acids pattern that's higher than this? She needs to eat more. Her 3-methylhistidine is okay, but that can be coming from breakdown of her muscle, the actin and myosin fibers. Her 1-methylhistidine speaks to a lack of dietary intake of protein. Her 3-methylhistidine may indicate breakdown of her own. She has a low omega-3 index, not surprising, and that's pro-inflammatory as well, right? So although her DGLA looks pretty good here, that's fine, but the omega-3 index speaks to a need. Oxidative stress-wise, look at her lipid peroxides. That's a big oxidative stress indicator. Her overall elemental markers look okay, although there was that low zinc, and you see it here. It is a bit on the low side. The toxic exposure looks good. So what do we have? GI effects, really low products of protein breakdown, a strong need for protein. Inflammation, the eosinophil protein X and IgA slightly elevated with a high inflammation score of in zone 4. A depleted microbiome, really underscored. Low short-chain fatty acids. Well, how is she going to make them without fiber, without anaerobic bacteria? The NutrEval, low amino acids, low intake. The NutrEval dysbiosis indication and possible inflammation. The kynurenic acid, a warning sign, a reaction possibly to inflammation. The omega-3 index low, that's pro-inflammatory. A lot of B vitamin needs, an inability to use fats for energy, and antioxidant needs. So our considerations, rebuild the microbiome, prebiotic, probiotic, fermented foods, fruits for antioxidant support, unprocessed foods, omega-3 supplementation, magnesium and zinc, calcium D-glucarate for the high beta-glucuronidase. It won't lower the beta-glucuronidase, but it'll block its effect to recirculate toxins in her gut. Support sleep, and maybe look at her thyroid and her hormones, like a menopause plus. She may well be perimenopause now, 6 months without a cycle. So that would be something worth looking at. So Lenore, that is case study number 2.
That is amazing. Thank you so much. We received so many questions, but I do want to share a few important things really briefly. Number one, I apologize for those who are unable to access the downloads during the presentation. You will have access to the presentation and the recordings within a week of the webinar. The second thing I would like to say is there were a lot of questions, people wanting more information about the commensal bacteria. You're able to download the Commensal Bacteria chart, which is available on our website under additional information when you go to the GI effects stool profile page specifically. So that way you will receive more information about the individual bacteria, how to help support them through the diet, how they can therefore help support the short chain fatty acids as well. So let's start with this question here. Regarding the methane dysbiosis score, what would be the next steps for following up if we have an elevation?
Well, one can follow up with a SIBO test just to see whether or not there is high methane. Remember that these scores, both the methane score and the inflammation score, the IAD, are based on inflammation and high methane, but the actual test itself, we're looking at the patterns. So I would, to confirm that the methane is high to the point where you're concerned with SIBO, I would run a SIBO test. And if it were positive, I would treat. And there are certainly prescriptive agents like neomycin along with rifaximin that you might want to look at, or botanicals, including garlic-based botanicals with high methane. But a high methane score does speak to a pattern that suggests that your patient will be having a higher methane. You might want to confirm that with the SIBO test, and especially if you're thinking about the need for fiber and prebiotics, because if they actually do have that diagnosis of SIBO, those can be problematic and increase abdominal distension.
I think you hit on a really important point there with regard to, we want to still consider a follow-up testing when we do have that elevation in the methane dysbiosis score. What about if the inflammation-associated dysbiosis score is elevated? What follow-up evaluation testing would you consider in an individual who presents with that?
Well, if you have an inflammatory score, there are things that you can look at, but I also would emphasize that means you have a lot to work on in the context of that GI effect. In terms of inflammation, I would look at the inflammatory markers and see whether or not they correspond to that score. And if the markers are high, for example, a high calprotectin would indicate a need to perhaps treat and or run an endoscopy or a colonoscopy. So it really depends on the markers of inflammation as they appear on the test. Remember, the commensal balance leads us in the direction statistically that there'll be inflammation. Check the inflammation and see where that looks. You have culture if there are bacteria, you have parasites to look at if those are involved. And I think that's really where I would direct my efforts first and foremost with a high inflammatory score.
Perfect. Thank you so much. Unfortunately, because the presentation was so great, I did not want to interrupt Dr. Goldman. I wanted him to cover both of those two cases because I found it to be very useful personally. But we're going to respond to your questions that were asked via email. We hope to get a response out within a week for all those who did ask wonderful questions.
And thank you so much for those questions. We look forward to them. And I know the timing, we had those two cases, and I'm really glad we got to look at both because they really both had some really strong differences worth your consideration.
Absolutely, absolutely. So for additional educational materials, we'd like to encourage you to visit our website, www.gdx.net, and or you can contact client services. We also offer complimentary appointments with our medical education specialists to answer any questions that you have related to testing, related to choosing the right test, or even reviewing results from your patients. So we also would like to encourage you to register for upcoming webinars on our website, again, www.gdx.net. As a reminder, we offer many non-invasive collection packs that can be shipped directly to your patients for specimen collection at home, and the requisition can be completed online. For further instructions or information, again, check out my GDX account. Lastly, if you have not already, please tune in to our lab report, which is focused on functional and integrative medicine, specialty laboratory diagnostics, and natural therapies with hosts Dr. Michael Chapman and Patty Devers and an assortment of wonderful guests. Thank you again, Dr. Goldman, for a wonderful presentation. Everybody have a wonderful day and please stay safe.